Anyways, as Dr. Merkel said, that he is the leader of this team, and I'm actually very, very proud to be part of this incredible team of people, and to work here and provide all the care and all the knowledge based on reading, studying, and what I'm learning from you guys. And I always, when I start my talks, I always say that tremendous amount of readings are put into these talks I always give. And to be honest with you, every time when you ask me a new topic that I have to talk about, I learn probably more than I could have ever learned just by myself. So the same applies to this, to me, fairly complicated topic, lung and stem cell transplants, partially because the topic itself in general population is not an easy one to talk about. A lot of studies, a lot of failures, a lot of complications, and we're dealing with patients who have who are fairly sick when it comes to transplanting an organ or multiple organs, or actually wiping out active cells that we have and putting them back, and the technology and everything around it. So this is complicated, and needless to say, when we're dealing with such a complicated disease as scleroderma, it becomes even more specific and even more controversial. So I will give you hopefully a good summary that is made me more knowledgeable about this, and hopefully makes you more knowledgeable about it, and with the hopes that down the road we will know much more about all the details. Okay, more to come. I was getting more and more into it. I said, all right, let's just jump out of it. So I, going back a little bit, referring back to Dr. Merkel's talk, it's extremely important that we have just like schemes. How does this disease, what happens exactly? So we call it susceptible host, which is really the person, the patient, right? And then something happens outside. So there's some sort of an event. I can't really tell what exactly. Is it a viral infection? Is it the vaccine? Is it the God knows what? Is it the stars were lined up in that particular way? So some sort of an outside event that triggers an maybe predisposed situation in that person that turns on a whole battery of responses. And it happens in the immune system. The immune system gets activated. It happens in scleroderma, it happens inside the vessel wall. Something happens with the structures that are there, so they become activated and therefore damaged. And they start communicating, the immune system and the vessels, right? And then not only that, but the third part of it in scleroderma is the skin cells. They become activated. And then all three, these, especially in scleroderma, these three participants communicate. Eventually, it results in, we call it end-stage pathology, which is what happens with the person, and again, dependent on which part of these contributes are more intense or more significant. That's what we see when we look at the person, when we look at the patient. So taking it a little bit further, so when we talk about skin, we have the fibroblasts, right, that are contributing to the disease pathology. We have the endothelial cells, which are inside the vessels. These become more activated. They obliterate or make the vessels more narrow. And then we have the immune cells, the B cells and the T cells. And Dr. Merkel talked about this. Remember the T cell medication that we may be using for the skin involvement of the disease. So understanding a little bit of these basics about how the disease develops, I spend always time on just putting the nomenclature down, okay? Because I ask my own patients, do you know what kind of disease you have? And they look at me like I just came from the Mars. And I always talk about this, right? So again, scleroderma is a layperson way of calling this disease, right? It just means thickened skin. But we have two forms of scleroderma, that simplified version, just localized to the skin, or systemic sclerosis, and that's what we are talking about, right? What we call scleroderma is really systemic sclerosis, which means that it's not only the skin, but also internal organs that are involved. The two groups, the grouping is really just based on how much skin is involved, right? Oopsie, I guess I just came out of my talk. Oh. Oh, no. Oh, wow. That was nice. I was trying to create a red light. Oops, AI happened. So when we're talking about the limited form, it just means it's limited below the elbows. The skin involvement is limited to the skin below the elbows, below the knees, and to the face. It becomes diffuse when the skin is more involved, diffusely involved. Okay? So that's the difference between the limited form and the diffuse form. And everything else, the inner parts are similar, roughly. So now that we have that, organ involvements in scleroderma, heart, you guys are very familiar with the pulmonary arterial hypertension, which is the increased pressure in the vessels that take the blood from the heart to the lungs. And the heart tissue itself can also be involved with this fibrosing disease, right? We have the lungs. Lungs can get inflamed, eventually become fibrosed, which is thickened. And we also list pulmonary arterial hypertension under the lungs because, it's really in between the heart and the lungs kind of pathology. Gastrointestinal, you guys all know, the food pipe can be involved. The bowels can slow down, and all kinds of other problems happen. The kidneys, I want to point out, scleroderma renal crisis is becoming a much, much rare of a complication of scleroderma. However, we still see that, especially at the beginning of diffuse form of the disease. It's really important that we are knowledgeable about that and we teach our patients about this particular complication. So, lung transplantation. Let's move to the first of the two topics of my talk. So lung involvement. So unfortunately, interstitial lung disease and pulmonary arterial hypertension are the leading cause of complications and death in scleroderma. Still the case. So interstitial lung disease, once it's diagnosed, it really means that the person has a poorer prognosis for the rest of their life. So still the mean survival time for patients who are diagnosed with severe interstitial lung disease is about 2 to 5 years from the diagnosis. So what happens is, in order to find these patients early on, even before that may develop, we have certain screening tools, right? And you guys know that we reinforce this over and over. Have you had your pulmonary function test done? Have you had your echocardiogram done? And then patients, oh yeah, well, 5 years ago, that's wrong, right? Every single time when you guys come in, I say it, I'm nice, I'm not nice, I'm giving the paper, I'm doing all kinds of things. I'm calling you, did you get it done? Where is your PFTs? Why don't I say a letter? And I just keep talking and talking and talking because this is really a crucial test that we have to have. We get the patients to do the breathing test. When I was a medical student, every time I give the paper, I think about how much headache I had after that, how dizzy I was. I hated doing it because we actually had to do it in medical school. I know it's a hard test to take, and sometimes we even have to do it with the mouthpiece that's not fitting in the mouth and so forth, but please get them done. This is extremely important that we get those parameters. We ask for the 6-minute walk test. Sometimes I see the pulmonary people are walking in a big stride and with the oxygen thingy, pulse ox on their fingertip. They're running, and I try to run with them. They're sometimes faster than I am. That's the 6-minute walk test. How far can you walk? Because that will also tell us about the functions and the abilities of your lungs. And we measure the oxygen content in the blood. That is also extremely important. Dr. Merkel keeps making comments, and I'm like, funny comments there. He's probably talking about my stride. And the echocardiogram, which is extremely important. Chewing so loud I cannot. This is the scleroderma team.
Hold on.
I know. Oh, all right. Echocardiogram is a non-invasive test. People lay down, they take the measurements of that, as we said, the pressures in between the heart and the lungs. So just a couple of pictures for you. Interstitial lung disease on the left-hand side. You see the lungs, both sides. They look quite hazy. That's not how they should. They should be nice and dark, right? We should only see a couple of little pipes and this and that. That is when the lungs become hardened, when they are inflamed and become fibrous, as we call it. Pulmonary arterial hypertension, as I mentioned it to you, it's really between the heart and the lungs. You see the nice wide open vessel on the left-hand side and the narrowed vessel on the right-hand side. That has to do with the inner wall thickening of the vessel. But I want to point it out that when the heart is pumping blood into the lungs, and you have the pipe in between, the pipe can be thinned, right? It can have just a small lumen. But you have to understand it, if you have a big resistance on the other end of it where the lungs are, the heart is not only pumping blood into that narrowed vessel, but also pumping blood against that fibrous lung that doesn't want to expand. So the poor heart, which is on the right side, the right-sided heart, has to work against narrowed lumen and the fibrous lung tissue. So the whole complex becomes one, right? We not only have lung problem and heart problem, but we have the combination of the two and the vessel issues. So it's really the lung and heart. Now you understand why if somebody has heart and lung involvement, why is actually that is a poor prognostic sign for scleroderma-related morbidities and unfortunately death. So lung transplantation. What is the purpose in general? What is the purpose of lung transplantation? To prolong survival and improve quality of life. It's a no-brainer, right? That's what we want. We want people to be able to walk, to be put it very simply, not to be short of breath, to be able to manage their daily activities, just, not even go to work, but actually go from the bedside to the sink to get a glass of water. Or when I call some of my patients up and she's on the phone, I'm talking, I say, why are you short of breath? She says, well, I have scleroderma. So that's exactly the problem. Sometimes even being on the phone is a problem. Just talking may become an issue. So we have been doing lung transplantations for about 30 years now. So it's a long time, but really not a long time, not long enough, unfortunately, to have a good grip on this, the whole process, and all the other relevant issues around lung transplants. So it is still somewhat controversial in scleroderma. And why is that? Because of the post-operative complications. And now this is the main issue with all the transplants, the lung transplants and the stem cell transplants in scleroderma. What happens after the surgery? What happens after the procedure? Why is that? Because unlike other people who got lung transplants for only lung problems, we have many other organs that are involved in scleroderma. And that's why I had the slide that kind of lists all these other issues that we have to deal with. So main ones are reflux, right? And my patients know that I am so keen on every one of you taking the reflux medications. Why? Because I always tell you, we are very intolerant to reflux because anything that's in the stomach, including acid, can come back up, and instead of staying down there, where does it go when you are laying in bed? Right into the lungs. When we have a problem with the lungs from the get-go, you don't want to put anything else into that may cause other further, fibrosis complications, burning from the acid, and so forth. Kidney disease, right? We have to have vital organs. And skin disease. And I will get back to that. So indications for lung transplant. So, well, not clearly defined, right? But we can say that it's probably same as it would be for other indications for lung transplant. We're looking at rate of progression, right? How rapidly the lungs are deteriorating, okay? And we're also looking at the severity of the lung disease and how much lung is being involved. What parts of the lungs are being involved? So who do we consider for lung transplants? We're considering patients who are free of other organ involvements or dysfunctions. We also consider patients, and I think that's crucial, who have an advanced lung disease that is refractory to therapy. Now, I want to point it out, refractory to therapy, which we don't even have. right? We do have some medications that we are using in scleroderma, but we really don't have a treatment for scleroderma lung disease. And remember, Dr. Merkel mentioned that we may get a study that's actually coming to our center, to the university, to address that particular problem. So again, we're looking at advanced lung disease that is refractory to therapy that we are trying, okay? And in patients who have a limited expected 2-year survival, okay? Now, I'm not capable of telling that. We have to collaborate with the pulmonologist doctors, and that's what we do. We discuss it. We discuss it as a team. So who are the patients who shouldn't consider lung transplantations, okay? So in general, people who have a lot of skin breakdown due to ulcerations, okay? Why? Because it's an open entry for bacteria. Now, when you have an organ inside you that is not even yours, you don't want to have, and you have a lot of immunosuppressant medications on board, you don't want any sort of an infection. I mean, infections happen anyhow, but when you know that actually that person is prone to have infections because of all those skin lesions and so forth, you have to unfortunately exclude these people because you're putting that person through a very, very strenuous procedure, and you're jeopardizing the outcome of the procedure, okay? We also have to exclude people who have rapidly progressive skin disease. In other words, their skin is becoming faster and faster, very thickened, right? And there are some data on the involvement of the chest. I put up the word Rodnan's skin score. That's the one that we pinch, and when we mark it on the paper. So maybe because of healing, okay? And people who have active muscle inflammation, those people should be excluded from lung transplant. Also, people who have renal dysfunction, and we measure that with different blood tests and so forth. And people who had scleroderma renal crisis, they are okay as long as that particular complication happened 5 years before the listing for lung transplant. We also have to, unfortunately, consider patients not apt for transplants if they have heart involvement. And now you understand it why I explained it to you. Heart and lungs work together as a complex. So therefore, we're looking for irregular heartbeat due to muscle involvement. We're looking for inappropriate pumping function because you need the blood to be able to flush the lungs and flush the body. Okay, so big one, esophageal issues, okay? So we consider patients who have esophageal dysmotility or gastroparesis. Now, unfortunately, almost every person has some degree of gastrointestinal involvement, right? But the people who are uncontrolled, we can't control them with aggressive therapy. People who have strictures in the esophagus, people who have obstruction in the bowels, those are probably contraindications for lung transplants. Now, interestingly, non-scleroderma patients, it's an issue in non-scleroderma patients as well. They have actually instituted this very finicky surgical procedure, right? They kind of wrap the stomach around the esophagus, so they're preventing everything that's in the stomach to come back up into the esophagus. Needless to say, these people can't vomit anymore, so, for certain, I don't want to say, you have a nice party and you want to vomit, nah. So it won't happen, but it prevents patients from this particular complication that acid and stomach content would come back into the transplanted lungs. Now, that has not been studied in scleroderma, so we don't know how that would work. But in non-scleroderma patients, that is a possibility if it's done early on to prevent the transplanted lung from becoming affected. So the question comes up, is it double or single? And interestingly, I faced this issue, and unfortunately, this patient of mine is not here today, and I wished she were. She actually has undergone lung transplants up at Pittsburgh. And with her, the main problem was that she had an extremely small chest cavity. So the normal person's lungs would not fit the chest. I mean, what an unfortunate situation is that, right? So she was extremely sick, extremely ill, and her functions were very rapidly deteriorating. And then the question came up, what is going to happen with her? Or is she, if indeed there is a lung that would fit her, is she going to get just one lung, or is she able to get a young lung, a young person's lungs, because of this particular problem? And luckily for her, she was able to get a double lung transplant. And she has been doing actually really well. And you guys know her. I can't say the name because of HIPAA regulations. But she did get the transplant about 3 years ago. But to be honest with you, it turns out that there is not a big difference between one lung or double lung transplants. It appears that when you get the pulmonary function test on these people, maybe the numbers they look better, but function-wise, and survival-wise, there is no difference between single lung or double lung transplants. So survival. It appears that the survival for lung transplantation in scleroderma patients is not different than for other people who get transplanted for pulmonary fibrosis. The problem is the early mortality. Early mortality meaning early on following the transplants. And it usually happens because the implant can fail. And I'm sure you're familiar with this many times. We hear this more often. We see transplants for kidney transplants. And that's when they say the organ got rejected. So the implant can fail. Heart events can happen. In other words, that's why I mentioned that the heart has to be apt for this particular procedure. Infections can happen, and interestingly, stroke. Late mortality can happen again because of infections, breathing failure. The medications that are given to prevent the rejection of the organ, that it's expelled from the body, can actually be sometimes associated with cancers. Okay? And again, heart events and strokes are particular long-term complications for lung transplant. So in summary, we have encouraging but limited data about lung transplants. It appears that we have similar survival in scleroderma patients to those with other end-stage lung disease. With a very careful selection of patients, we can offer that particular procedure to our patients when they are at that stage, as I mentioned, as I explained it to you. And due to lack of lung transplant, single lung transplantation is a good option, maybe a good option for our patients. Okay? All right, moving on to the second topic. Stem cell transplantation. Okay, how are you guys doing? Still keeping up with attention? Wow, I'm getting down a little bit here. So, stem cell transplantation, I'm going to abbreviate it as SCT throughout my slides, also called bone marrow transplantation. What happens in this process is the diseased bone marrow is replaced by highly specialized stem cells. You may be familiar with the word stem cells, right? We had some political issues regarding that. So stem cells are these actually very interesting cells that stay inside us, and they really not designated to do anything, but they can actually differentiate or turn into a kind of cell that's needed in the body. So they can undergo very quick differentiation as we go, as we say this, and rapid multiplication. So they can become blood cells, they can become skin cells, they can become heart cells. We are understanding more and more about these multipotent stem cells, as we call them. Here I'm just mentioning that there are 3 cell lines or blood cell lines that can grow, or these stem cells mature into the white cells, the red cells, and the platelets. These are the ones that we always check for when we are checking we call them CBCs, Remember when we check for white cell count and hemoglobin and red cell counts and platelet counts? Okay? So this differentiation happens based on signals that the body actually passes on to these cells. So there are all kinds of chemicals and factors that can trigger these cells to undergo, as we call it, differentiation and multiplication, and they can actually go to that place where the cells are needed. So they can actually replace the bone marrow, okay? And when we talk about transplantations, we use these words autologous or allogenic, okay? Now, auto, you should be familiar with the word. Auto means self, like autoimmune, right? It means self. So that means that you're actually taking the patient's own cells, you do all kinds of things with it, and you put it back into the person, right? So now that runs the risk of you say, well, you're putting it back to me in my own bad cells. That's true. That may happen. So that's why we have to actually very carefully remove certain cells from the blood. So what we're giving back is potentially a healthy cell. However, the stem cells, because we believe that our disease is somewhat genetically predisposed, they can have that genetic problem inside them, okay? Allogenic, though, when the cell is coming from another person, relative or a lucky person, like in this patient's case, when you find actually match, right? We have to match these cells. And you can take these cells from another person and put it back into the diseased person, so healthy to diseased person. Now, the problem is that that's not self, right? So your body will recognize that cell as it's coming from the neighbor. And your neighbor may not be your good now. So that cell comes from somebody else, so therefore the immune system doesn't recognize it as self and can do all kinds of bad reactions can happen, right? So this is what happens. I'm only going to talk about the autologous stem cell transplantation because that's what we do in scleroderma. So the patient's stem cells, as you see, are collected, okay, and are being frozen. So what we do is we actually remove every other cells, the green and the orange color cells. These are active immune cells. Remember I showed you the B cells, T cells. We remove these cells. And we just keep the stem cells, which are the blue cells. These cells are being frozen, right? And then they're being stored. So then what happens is we actually treat the person, the sick person. We give them chemotherapy. We give them all kinds of growth factors. We give them radiation therapy because everything needs to be removed as much as possible in order to get rid of the bad actors, okay? So this is a pretty serious process. So the person who undergoes this procedure, you know, we have to make sure that they are staying as healthy as possible, and we are selecting the right person for this procedure. It's possible, but we have to be careful how we are selecting. So that person is now, let's say, free of these bad actors, has undergone all the chemotherapy, has undergone the radiation therapy, which already we know is a no-no in scleroderma, and I will talk about this, right? And then when that is done, what we do is we inject the blue cells, which is the stem cells, back into the person, hoping that it will eventually go into the bone marrow and then start to differentiate. And so the person has the cells back again in the bone marrow that are necessary for life, right? And removing the immune cells that we believe were the bad actors, the bad factors that were maintaining the disease. I'm simplifying this, okay? So it's a simplified version. Okay, so what is the rationale in scleroderma? Now you know the basics, so what's the rationale in scleroderma? So we believe that these transplanted stem cells have some properties that may actually inhibit the inflammation, the proliferation. They may help with the immune system to reconstitute the immune system. And they may induce self-tolerance, right? So we will not attack our own body because of this disturbed self-recognition, okay? So also, interestingly, they found that patients who had cancers and they also had autoimmune diseases, when they were treated with stem cell transplant, they actually cured or improved their autoimmune disease. Okay? So they said, oh, maybe that would be actually a new way of approaching these autoimmune diseases. However, you have to know that some of these patients got allo transplants, so from somebody else, which actually brought on a scleroderma-like reaction. We call it graft versus host. So what was given from outside actually attacked the person. So that is a complication, and that is why we are not doing allo transplants in scleroderma. So the phase 1 and 2 trials, remember Dr. Merkel's slide, showed a risk and a benefit ratio. Everything has to be weighing in. We're doing all these things. What is the benefit at the end? So these early trials that involved very few patients show that that may actually be more beneficial than risky. So in general, who are the patients who are selecting for stem cell transplant? People who have life or organ-threatening autoimmune disease, okay, who are refractory to conventional therapy. And I highlighted this because that is one of our problems, conventional therapy, right? Sufficient patients who have sufficient reversible pathology, which means that whatever is happening by doing a stem cell transplant, I can actually reverse, okay? Because if something is not reversible, again, the risk and the benefit ratio is going to be more a risk than the benefit. Patients who have decent quality of life after cessation of inflammation, meaning when I'm helping this particular inflammatory process that's happening, the patient can actually resume a normal quality life, right? And again, risk and the benefits. So, in 2002, there was a meeting in Italy who actually analyzed the data that were available from patients with autoimmune diseases and stem cell transplantation. They found that patients, what are those parameters that we have to look at? They found that heart assessment was a high priority in these people. Why is that? Because the medication that we are using when we are treating the patient's bone marrow is called cyclophosphamide. It's one of the drugs. It's a very, very potent chemotherapy. It actually also has side effects on the heart. So we cannot give a medication that will potentially affect a vital organ that can also be affected by scleroderma. I hope you're understanding these chain reactions. So in other words, patients needed to have all these evaluations. They needed to have blood tests that would assess the heart strain, how strained the heart is. Patients may also need to undergo, with scleroderma, right heart catheterization for pulmonary arterial hypertension, because that may be an indicator of poor heart function. Patients also needed to undergo lung evaluation. They needed a high-resolution CT scan, CAT scan. You guys are familiar with that? And what they found was that the phase 1 and phase 2 studies revealed the potential problems. The potential problems are in scleroderma tolerating infections and fever because of the internal organ involvement. People with scleroderma had a lot of problem with tolerating volume overload that actually is part of stem cell transplantation during that process when we are taking the cells out and then when we are treating the person with high-dose chemotherapies. The other side effects or potential problems are infertility. I mean, clearly, if you're treating somebody with so potent medications, rapidly multiplying cells, such as the cells in the ovary, the eggs and the sperms and so forth, they are going to be affected with the potent chemotherapy. Patients may be at risk of developing cataracts and also late cancers. As I mentioned, that high-dose chemotherapy is always associated with late cancers. So Therefore, the recommendation is that patients with heart and lung problems, and these are the particular parameters, should be looked at and either excluded or included if they have this particular involvement. Very importantly, we have to shield organs. Remember I mentioned it, that you need, that part of the stem cell transplantation is radiation. Radiation itself is, can bring on or brings on thickening, fibrosis. It brings on thickening and fibrosis of the skin, and especially the lungs. Lungs are very prone to radiation-induced fibrosis. So when you have a disease that is already associated with lung fibrosis, if you're putting radiation on it, it's going to be even more affected. And they also found that these conditioning agents, the ones that are given to the patient to remove the bad actors, to treat the bone marrow, they have to be individualized because of the side effects and the potential complications. So the clinical trials, early 1 and 2 phase 1 and 2 studies showed that there was definite improvement in skin scores and activities of daily living. They found that the kidney, heart, and lung functions were unchanged. They also found that, unfortunately, there were high treatment-related deaths. For the 41 patients who have undergone these early phase 1 and 2 studies, actually there was in the first 12 months of follow-up, there was 17% mortality. That's close to 20%. So when they added additional 24 patients, they found that they were able to lower that early phase treatment-related death to about 12%. Interestingly, in this study, they used many different chemotherapies and many different methods based on how they were going along with the study. They found that the complete or partial remission in these patients were seen in about 2/3 of the patients. So when we look at a US-based study that involved 19 patients, these patients also received, as you see, cyclophosphamide, chemotherapy. They were also using radiation for these patients. The TBI is total body irradiation. They found that when they looked at 14 months median time of these patients, they found that there was a marked improvement in skin scores. So the skin improved markedly following stem cell transplantations. Unfortunately, though, early on, there was 25% mortality in these people, if you look at the right-hand side of the slide. And therefore, they started using shielding that actually resulted in much less mortality, early mortality. When they looked at 4-year data, they found that the skin improved markedly, the lung and the heart and the kidney functions were stabilized, and there was still very high mortality, 23%. In France, there was another small study. They used a very high dose cyclophosphamide for these people, but they used no total body irradiation. So they took out that particular complicating factor. They found that there was much less death with these procedures, and they still saw marked skin improvement, and they found that there was lung and heart and kidneys were stabilized wherever the patient was at that point of the study. If you look at some later studies, you see that there are some newer studies, in one from the Netherlands and France, and another phase 1 study that showed that much less aggressive chemotherapy to the patient and no radiation actually showed much less early mortality in these people and showed sustained skin improvement in these patients. So these studies prompted the 2 big trials that we have at this point, the ESTIS and the SCOT trial. The ESTIS is actually completed. That involved 156 patients, And this was a placebo-controlled study. So you see 79 patients were treated with high-dose chemotherapy and radiation and stem cell transplant. The other half of the patient population only received monthly chemotherapy. Okay, so they didn't receive stem cell transplantation. Okay, so the outcome of the study, or the design of the study, was to see whether stem cell transplantation or monthly intravenous chemotherapy are more beneficial for long-term event-free survival. Event-free survival is death related to an organ involvement or significant disease that happens due to lung, heart, or kidney involvement. Okay? So the study is completed, as I mentioned it to you, and what the study found was that there was early mortality related to the treatment in the first year, and that is 10%. However, after that, there was no increased mortality related to the study therapy, and they actually found that the stem cell transplantation provided a long-term event-free survival as compared to other people who got the monthly cyclophosphamide therapy for 1 year. Okay? There is another study, the Scott study, that is still ongoing. The aim is 226 patients. It is similar to the Estes study in a sense that it is also using chemotherapy, radiation therapy, and the outcome is very similar to the Estes. The design is very similar to the Estes study. It is looking at a long-term event-free survival. However, as you see, instead of 200 milligrams of cyclophosphamide per kilogram, it's only using 129 milligrams of cyclophosphamide, so they are trying to lower the chemotherapy dose. And they are also comparing it with monthly cyclophosphamide treatment for 12 months. The study is probably going to be completed in the next couple of years. So we will have data in terms of what are the early mortalities related to the treatment. So in summary, stem cell transplantation is a potential treatment for a well-selected patient population with well-defined disease state. Unfortunately, it is still associated with high early mortality, meaning in the first year related to the treatment. It shows, however, good long-term outcome in terms of skin improvement and internal organ stabilization of function. So the questions are still who should be considered for stem cell transplantation and what would be the best treatment protocol for these patients. And that's what I have for you.